Hello, my name is Doreen Landa, and I'm the Executive Director of Advancement at the University of Toronto's Temerty Faculty of Medicine. I'd like to begin today's event by acknowledging the land on which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are truly grateful for the opportunity to work on this land. And I'm so pleased to welcome you today to this latest installment of our Temerty Medicine Talk series, Renewing Canadian Healthcare and Solutions from Family Medicine. Despite its many strengths, Canadian healthcare faces longstanding challenges that have become even more apparent and certainly exacerbated throughout the pandemic. One approach to change could be by putting family medicine and primary care at the center of health system rebuilding. And we are thrilled to have Dr. Danielle Martin with us today to share more on this topic. I hope you enjoyed today's discussion and look forward to hosting more Temerty Medicine talks in the future. I'd now like to welcome and perhaps welcome back Trevor Young, Dean of our Temerty Faculty of Medicine, to say a few words.
Thank you, Dorina. It is my sincere pleasure to welcome you all to this Temerty Medicine talk. I'm also absolutely delighted to be back in the Temerty Faculty of Medicine, having recently completed my term as acting provost for the University of Toronto. As many of you know, the Temerty Faculty of Medicine is at the core of this research and educational hub of our world-renowned health sciences network with University of Toronto and our amazing hospital partners. Every day, our researchers, clinicians, educators on campus and in the hospitals tackle medicine's big questions, working to develop innovative solutions which are both scalable and potentially will have global impact. And Danielle Martin is certainly no stranger to big ideas or tackling tough questions. In addition to being a family doctor, researcher, and educator herself, she has also recently been appointed the chair of University of Toronto's Department of Family and Community Medicine. This outstanding department encompasses over 1,900 family doctors across the province, from rural areas to urban centers. With its tremendous size and scope, the research and training within this department truly is uniquely positioned to impact and perhaps help reimagine health and health systems at the local, national, and global level. And I'm also so pleased to have Andre Picard, the award-winning health columnist for the Globe and Mail, back with us to help guide today's conversation. Thank you so much, Andre, again for being with us and for your continued support. I'm going to turn it over to you now to introduce today's topic and speaker. Thank you.
Thank you very much, Dr. Young, for that introduction. And let me welcome our special guest today, Dr. Danielle Martin. She's the chair of the Department of Family and Community Medicine at the Temerty School of Medicine, the largest department of family medicine in the world. She's also a practicing GP, and you can read a lot more about her in her impressive biography, which we've posted in the chat. We only have 45 minutes, so I'm not going to read that. So we have a big and timely topic today, Danielle, the role of primary care in renewing Canadian healthcare. So I want to jump right into it. And I want to start with a really basic backgroundy question to help our audience get situated. I want you to tell me, what is primary care? Why is it important?
Sure. Well, the dictionary definition of primary care is it's your first point of contact with the health system. Most of the time, for most of us, that means our contact with our family doctor, or you might see a nurse practitioner or a team for your primary care. But it does also include emergency departments. It includes walk-in clinics. It's the place at which you come into, the door that you use to enter the health system. In practice, though, when we talk about primary care, most of the time, we are talking about family medicine. And the difference between family medicine and all those other kinds of primary care that I mentioned, like emergency rooms or walk-in clinics, is that primary care in the family medicine context is really about what we call comprehensiveness and continuity. It's about relationships. And so when people ask me, well, why are you a family doctor? Why didn't you choose to specialize, in quotes? I always say I do have a specialty. I specialize in relationships. My specialty is the specialty that looks at whole people through the whole course of their lives, from the day that from before they're born actually until the day that they die, and all of their body parts. And so we don't specialize in body parts in family medicine. We specialize in relationships, and that's what primary care and family medicine are all about.
And that's on the personal level. The primary care is also the foundation of our health system, right? And if the primary care is shaky, the whole system is kind of shaky.
Absolutely. I mean, it is not possible to build a healthcare system with enough pediatricians to take care of all the babies and enough geriatricians to take care of all the elderly people. Primary care is the absolute foundation of all high-performing health systems. And so when we look at health systems around the world, and this is why the World Health Organization, for example, is so focused on building primary care and family medicine in countries where healthcare systems are still being built. Health systems that have strong primary care systems where people can get easy, ready access to high quality primary care services, those systems give better health outcomes and better equity at lower costs. It's not realistic, and it's not feasible, and it's not affordable, and it's not actually good for you to exist in a world where you just have a different specialist for every part of your body. It is much better to deal with somebody who specializes in generalism and taking care of the whole person. And then those other parts of the healthcare system, which are critical and which we need, come in and then exit out again as they're required.
Now, you mentioned easy, ready access. That doesn't sound like Canada to me. Do we have a strong enough foundation of primary care, or do we have to work on it?
Not yet. And you know, the pandemic sure has shone a light on that, hasn't it? I mean, those of us who have had experience of being able to build that relationship with someone we trust and who knows us over time know how critical that is when things go badly in your life, in your health, you know, cancer diagnosis, disintegration of a workplace situation or a marriage, a sick child. I mean, these are the moments where we really need access to our family doctor. And we know that about 85% of Canadians do report that they have a family doc, which is a good start. You know, 85% is not bad. It'd be much better if it was at 100%. And I'm sure we'll talk more about how we get there. But even those people who do report that they have a family physician report that they have a hard time getting in to see that person. And so, you know, Canadians have very low rates of being able to access their provider within 48 to 72 hours of calling, for example, as compared to people in other countries, other jurisdictions. And that's, you know, critically important, because if you can't get in, doesn't matter how great the care is, if you can't get in, then it's not doing you much good. And we know that that's a problem all across Canadian healthcare, not just in primary care and family medicine. Once you get in, the care is generally quite good, but we do have real challenges with access. And I will say also that those challenges are not evenly distributed across the population. Some groups, some neighborhoods, some parts of the province and the country have a harder time than others. And we really need to pay attention to that if we want to build not just a better health system, but a more fair and just health system.
And we'll come back to that. We'll come back to access and inequity of access. But you mentioned the pandemic, the elephant in the room. We're still living this pandemic 2 years on. What has the pandemic taught us about primary care in particular, and some of the strengths and weaknesses of our health system? And we only have an hour, so we'll try and keep it to the
I'll try to keep it brief. I mean, I will say that to me, we should be careful, and you have written beautifully about this, Andre. We should be careful about pretending that we really learned anything new in this pandemic. The things we already knew about our health system have come to the fore in ways that I think and hope can no longer be avoided. But these are not new problems. We had problems with wait times for healthcare services in Canada, non-emergency services before the pandemic. Those can be expected to be worse in many areas now. We had problems around care for seniors, and the ability for our elders to age at home and get the supports that they need, or be able to depend on high quality care in long-term care facilities before the pandemic. Those were issues well before and well documented, including by you. And those problems certainly came to the fore with the high rates of death in long-term care, particularly in the first wave. And we have seen in family medicine and primary care, especially, I would say, I mean, throughout, in terms of access to vaccination, access to testing, and access to ongoing services, because people didn't stop needing care for their diabetes or their schizophrenia or their well babies or any of those things through the pandemic. So those access issues really came to the fore in the pandemic. And now in the recovery, they're going to be incredibly important issues, because we know that there is a lot of care that went deferred, that people did not access over the last 2 years. There's a lot of, I don't like the word catch up, but it is sort of a catching up in some ways that has to take place. And for people who are untethered or disconnected from their family physician or their primary care team, that work is going to be very difficult to achieve. So this is our moment. If we don't fix family medicine and primary care now for the people of Ontario and the people of Canada, we will not recover from this pandemic in our health system in a way that is sustainable. And that's in my opinion, it's the most critical issue we've got. You know, we can deal with the backlogs of hip replacements. That's really important. It needs to get done. But actually, this is much more fundamental, connecting everyone to a family physician, making sure that they can access that family physician, making sure that they have that relationship, and that quarterback, that coordinator of your care, is the most pressing issue of the health system recovery, in my view.
Well, and I was going to ask that. We talk a lot about the backlog in surgery, but we don't talk about these other backlogs, the lost relationships, et cetera. Can we do that? Can we catch up, especially with a workforce that's burned out, that's overwhelmed at times?
Yeah, it's going to be extremely hard. And we know that just as we're hearing about large numbers of nurses saying that they're going to be retiring early after the last 2 years of working their guts out in the hospitals, we also know that many family physicians are talking about potentially retiring. And that has huge implications. You know, if a person with a practice of 2,000 patients retires and there isn't someone to take over, that's a massive loss to a community and a neighborhood. And there are also big economic implications. You know, people, when they move to a community, want to, move for a new job or whatever it is, if you can't access a good school for your kids and a family doctor for your family, then you're not moving into a community that is exhibiting signs of welcoming you. And that includes people who are immigrating, newcomers to the country. It includes people who are, moving from one part of the country to another. So I don't think we are talking enough about this. And I do think that the university and those of us who study these problems and issues for a living has a really important role to play in trying to elevate that conversation, because thankfully, I mean, you need a cataract done, that's really important, but you've only got 2 eyes, is only so long that your focus is going to be there. But actually, that primary care relationship, we all need it, and we need it for our whole lives. It's the beginning, middle, and end of our interaction with the health system.
And I hear from people every single day who say, my doctor's retiring, my doctor can't see me, she's too busy. What practical advice can you give people? I'm sure there's many in our audience who are in this situation. What do you do when you don't have a doctor? Do you just go to a walk-in clinic, or?
Yeah, I mean, of course, the first advice, which is really, it's shameful that I have to give it, is just don't give up. Until we have in place more sane and rational and well-organized ways for people to get connected to primary care, which exists in other countries, by the way. I mean, if you move to many parts of Europe, you'll simply just be given a card that says this is your local GP, and they're now your doctor. And so there is hope. It's not beyond us to organize these things. But until such systems exist here, continuing to try to, are there lists that you can get on? Are there colleagues, friends, family members you can ask to help? And I do see signs of hope. We are seeing the team-based primary care models in Ontario for the first time in many years now being reopened, which means that Our new family doctors who are graduating from our programs will be able to join teams that were previously closed and can take on new patients. There are, of course, teams that don't include doctors, that are led by nurses and nurse practitioners and others that give great primary care, and especially, but not exclusively, in many rural parts of the country. So there are options. And yes, I mean, this is why Canadians are big users of emergency departments, and this is why Canadians are big users of walk-in clinics in part. These are complex things, but in part it's because either people don't have access to a family physician or can't get in to see that person at a, in a timely manner. And that is the work that lies ahead for us, I think, as a health system and as a discipline. And it helps when patients and the public signal that this matters to them. It helps to get the issue on the agenda so that we can begin to address it.
It's a little, for me, it's like the Canadian version of Survivor. I hear people just scrambling around desperately to find a doctor, to get an appointment, et cetera. Now, you mentioned teams, and I didn't mention, but we had a lot of questions that came in advance, maybe more than 100 of them, which I've grouped into categories. And one of the most common was about teams. Why don't we invest more in teams? How important is teamwork for a family physician? Maybe you can talk about that a bit.
Absolutely. I mean, there's no part of the healthcare system that doesn't do better when you put a team in place instead of an individual. I mean, I would argue that that's the case in almost every part of the economy, not only in healthcare and in medicine. And there are sort of two levels of team, if you will, when it comes to my discipline. The first is doctors in teams together. And those teams are critical because that's what allows family physicians to cover each other, to offer evening coverage and weekend coverage without having to do 24/7, each of them as individuals. If they need to share an electronic record so they have access to the chart. It's also what allows academic family doctors like me to also teach and do research and leadership and other things and still know that our patients are cared for in that broader team context. And so getting to know not only your individual doctor, but the team they work with is important. But the other thing is, of course, the doctor is not the sole member of a high functioning team. Primary care includes nurses, it includes pharmacists, social workers, physiotherapists, OTs, et cetera. And those team members are critically important because much of what we do in family medicine and primary care is the management of chronic disease. It's the management of mental illness. It's the management of diabetes, hypertension, heart disease, lung disease. I mean, this is the bread and butter of our discipline. And actually, that multidisciplinary team provides much better, higher quality care than any single individual could ever do, and also stretches that doctor as a resource further. And this is really important. So, if we say, well, lots of Canadians don't have a family doctor, does that mean we have a shortage of family doctors? Maybe. Maybe it means that we've got a family doctor shortage if those family doctors are all working as independent individuals and now you put them in a team. Each of those people can see a lot more patients. And so actually, sometimes it's about training more doctors or getting them making sure they're distributed to the places where they're needed. Sometimes it's about getting them to work differently and smarter, and almost always differently and smarter means a team.
And is the solo practice, is that dead or should it be dead?
I mean, I think it's becoming increasingly a rare bird. There may be some places where the solo practice still makes sense or is the only option, but I don't see our new graduates wanting to choose that mode of practice. And so one of the big ironies of the last several years, certainly in the GTA here where I live, has been that we're graduating these amazing young new family doctors out of our program who trained in teams and want to work in teams, and then they couldn't get a job. And meanwhile, you've got all these people who can't get a family doctor. So that's a serious public policy error. It's now being rectified. And now that our graduates will be able to access those team models, I think things will start to ease here in this part of the world where I live.
And there's a dizzying number of team models around the country, all these acronyms that I can't keep up with. Is there an ideal model? Is there one way we should be doing this? Or how do we figure out the right team model especially for new graduates who want to work this way?
No, I don't think there's an ideal team model. And this is one of the beautiful learnings of the pandemic, I think, is that we saw outreach into communities for testing and vaccination out of primary care and also out of hospitals and public health units at a level that certainly in my career, I've never seen before. I've never had the opportunity to work in so many high school gyms in my whole life as I have over the last 2 years. And that is how you get to know a community. And so, in some neighborhoods in the city of Toronto, where rates of diabetes are really high, your team probably needs full-time diabetes educators just doing that work. And hopefully they're members of that community who are trusted, who speak the languages that the local population speaks, whose kids go to the schools there, who can, really interact and engage with people. In other parts of the city or the province, there you may happen into a community that's near a major hospital that serves people with mental illness. And so you may need a primary care team that's got a real focus on mental health. And we see that, here, for example, in the city of Toronto near CAMH. And so it depends where you are and the population you're serving. It is such a fundamentally local thing, healthcare, right? And so we can put in place good policy at the high level. We're going to pay for teams. We're going to allow people to get into them. But then the decisions about what the makeup of the team should be have got to be local.
And I've heard you say you want to put the community back in the Department of Family and Community Medicine. That's what you're talking about.
It is a big part of what I'm talking about. We at the DFCM, we're having this conversation right now. What is the C in DFCM? What does it mean to be a Department of Family and Community Medicine? And a big part of that is to be clear about who is our community, who do we serve, and how do we align our clinical care, our research, our education, our quality improvement, even our global and health and leadership work to really serve those communities. And that is another one of the hard lessons of the pandemic. I mean, we've all seen in the papers and online these maps and graphs that show who paid the heaviest price over the last couple of years. And those maps tell a very important story about our city that this great university is located in. That ring around the downtown core, the inner suburbs, Mississauga, Scarborough, Humber River region, where we saw emergency departments and ICUs full to overflowing. We saw high numbers of essential workers, people from racialized communities, people living in multi-generational homes and high-rise buildings being felled by this virus, and other parts of the city where it was almost, I wouldn't say hard to tell there was a pandemic at all, but really much lower rates. And those ran along income lines, and they ran along racial lines, and they ran along geographic lines. Well, what's our job as a university and as a faculty of medicine and as a Department of Family and Community Medicine? If we don't learn from that, then shame on us. And so I think that we have got a real job to do around thinking about the implications of these last 2 years and what we've seen in terms of our academic resources and how we're going to show that we are actually capable of learning.
Yeah, and I think the pandemic really happened at this intersection of ageism and racism and sexism. It disproportionately affected elders and racialized workers and women, particularly working women with children. How can family medicine tackle these isms, or is it your job to do that?
It must be our job. And I think to me, there are sort of 3 levels on which we must tackle these questions. The first is the level of our practice. So we do a lot of work in educating our learners around how to screen and ask about things like poverty and ask about, are you able to make ends meet at the end of the month, to identify people who are at risk, asking about whether people have drug coverage before you hand them a prescription, trying to figure out how you're going to problem solve for that individual person. So that individual level is there, and it's very real. We all do it every day. Sometimes we don't do it as well. Often we don't do it as well as we need to. The second level is at the practice level. How do we organize the practice of medicine to serve communities? And that's about, where do you locate your office? What hours are you open? Are you on the second floor without an elevator? Do you have, wheelchair accessible bathrooms, washrooms in your office, et cetera? And so all of these choices, what languages do the people speak who answer the phone in your office? Do you offer same day appointments? Do you participate in quality improvement? So all of that practice level stuff really matters to the ability of people to access the service. And then the final level is at the level of the system. We need to be advocating for improvements. We need to be doing cutting edge research to answer the important questions about how do we respond to the needs of communities. And we need to be getting that research out there and pushing for improvement at the level of healthcare policy, being thought leaders and public intellectuals, and sometimes being, a pain in the butt of decision makers, which I think is really important for a university where the diversity of thought and intellectual enterprise is what we do for a living.
And a lot of what you just talked about is all about the social determinants of health. It's about income and housing and connection, education. That's something that during the pandemic, we started using that term quite commonly. I guess is that a silver lining in this, that people are understanding that connection between welfare and health and vice versa?
I think it has opened up a conversation in a whole new way. And it saddens me, of course, that we've had to learn the lesson so painfully, but I do think it's a gift. We no longer have to try to explain why it's important to ask whether someone's got safe housing when they're coming into the hospital or being discharged from the hospital or coming into the office. And that is new. You've experienced it, Andre, as a person who helps to lead public opinion on this. People are talking about the social determinants of health in a way that they never did. And I will say that my colleagues in infectious disease, in intensive care, who've been working the COVID wards throughout the pandemic, have also really helped to elevate these issues, because you cannot watch who comes in sick and who dies and not notice some patterns. And so that is then on us to speak out about as people who care about health.
Now, you mentioned in passing research. We have this impression that research is all about specialists figuring out if drugs and surgeries work. What's the role of family medicine and primary care practitioners in doing research?
We have a huge research enterprise in primary care, and there are a whole bunch of areas in which that's relevant. I mean, if you think about it, most of the prescriptions for those medications you named that have been that we imagine to be happening in big specialty areas, actually most people get their prescriptions from their family doctor. And so understanding how medications and treatments and diagnoses work in the place where people get most of their health care, which is in primary care, is really important. But we're also doing research in a whole other realm of work, which relates, for example, to virtual care, the use of technology, thinking about how services can be delivered in ways that are convenient for people and still give them high quality services. We do a lot of work around healthcare policy and how systems of healthcare should be organized. So, primary care research is a booming industry. And we at DFCM here at U of T have the second most academically productive department in the world. I've let our colleagues at Oxford know that we're coming for them. We'll be first soon enough.
I think there was a car company used to have a slogan, "We're number 2, but we try harder." So maybe we can steal that one.
That's a good one.
Now, there's a lot of learners in the audience too, and you mentioned there's a role for research for them to do in the future, but there's also a role in teaching. You have a huge faculty. I know there's interest in younger people teaching. Talk about that a bit, about family docs.
Yes, the faculty, when we have 2,000 family physician teachers, faculty members in our department. So, it is the biggest in the world. And we, at any given time, are training hundreds of family physicians and medical students in the art and science of family medicine. So it's a massive educational enterprise. And the teaching, of course, is bidirectional. Like, that's one of the joys about working in education is we're helping our learners to develop the skills that they need to be great family doctors. And they are also keeping us on our toes as faculty members, demanding the best education from us, questioning what we're doing. And so it's a beautiful interplay. Our residents also help to teach our medical students. We have programming around teaching residents to teach. So it is education is the core of what we do. And we all get out of bed every morning to try to train the family doctors for the future. But, the way in which you do that is also an area of research. And so this concept of education scholarship and asking, well, what is the best way to train a family physician to be aware of the social determinants of health? Do you do that through simulation? Do you do it through lectures? Do you do it by having them follow a person experiencing homelessness through their journey of the healthcare system? Like, what are the question about how we do education and how we do it well is also an area of big focus for us in our department.
Yeah, and I think that's become a big issue in med schools all over the world, is how do you just put stuff in people's heads, or do you teach them how to learn differently?
Yeah, and this, of course, in generalism is even, I would argue, even more important. I mean, many of the medical students who I interact with say, well, family medicine's cool and I like the relationship part and knowing your patients over time and everything, but you just have to know so much, like, how can I possibly remember everything about neurology and everything about nephrology and everything about, and I say, well, actually, like, the expectation is not and should never be that you're going to know everything. By the time you finish learning it, it's going to be out of date. It's about knowing where to look. It's about knowing what to ask. It's about knowing how to continue learning, and also how to effectively use your specialty colleagues and the rest of the healthcare system to get answers for your patient when you don't know them. That's the art that we need to teach our generalists so that they're not afraid of the breadth of our discipline, but rather understand that their core skill set is moving in and out of learning for their whole lives.
Now, to come back to the pandemic again, sort of my obsession for the last few years, one of the silver linings in this is the embrace of virtual care. We've learned how to use telemedicine. Can you talk a bit about that, the good and the cautions you might have about family docs using virtual care?
Yes, and of course, in Canada, virtual care has really primarily meant the telephone. So, this brand new technology called the telephone that we now use in healthcare. But it has been a massive change in a very short period of time. And of course, we did it at the beginning because it was the safest thing to do when we were trying to keep people home as much as possible. And at that point, we then learned that for many, not all people, it was also a much more convenient way to access care. And for some people, it was actually allowed them to access care that they wouldn't otherwise be able to access, because some people can't take half a day off of work to come to my office and sit in the waiting room. But I can call them on their lunch break and we can have a conversation, and suddenly that opens things up for them. So that's been, important. And of course, the advent of the video visit and use of video technology, which works well for many people, not every person, all of that's been really great. And so the question is now, what are we going to do? Because some things do require a face-to-face visit and a physical exam. And this is an area where the research, I think, is going to be really booming over the coming months and years. How do we determine, if you've got a rash and you call my office and you email me a photo and I look at the photo and I talk to you on the phone, that may be good enough. If you've got abdominal pain, you got to come see me. I can't assess that over the phone. I need to examine you. And so figuring out what are those algorithms, what's the negotiation between physician and patient around that? Where's that sweet spot between the agenda of the patient and the agenda of the healthcare worker? And then what are all of the many ways that we can use digital tools? So it can't just be the phone. It must also be the photograph, the email, the secure messaging, the video visit, the e-consult, the e-referral, the telephone backup of specialists to primary care. Like, if we're going to do this, let's do it well. Let's look at all of the available technology. And that's before you even get to the application of artificial intelligence and big data. Then you can really start to have some fun. And so I think there's a lot of, a door has been unlocked here. I hope we don't choose to simply continue to sit on the phone, but rather use this opportunity that the pandemic has afforded us to rethink how technology can transform the way that we deliver healthcare services.
And there's always an equity part to the technology as well. Not everybody has a computer or high-speed internet. Some people are in remote areas. How do you find that balance?
Yes, and what's interesting is, and we have, I'll mention Dr. Suzanne Schusch, who's our Indigenous health lead in the Department of Family and Community Medicine here, has done incredible work on this. I mean, there are ways to organize virtual care that work better for people from equity-seeking communities than our traditional. Like, let's not kid ourselves that the face-to-face visit is super equitable as a tool. A lot of people have been left out of the traditional models, but Suzanne and her colleagues have a service called Call Auntie, which is for Indigenous women primarily, who call this number, and you get a healthcare provider right away. So you don't need an appointment, and you don't need to come in, and you get on the other end of the line a person who can give you culturally safe care. And it's been proved to be an incredibly effective way to provide COVID-related and other social determinants related supports and care to people using this phone line. So actually, if you design it right, virtual care can be equity enhancing, but you have to begin by asking the people you want to serve what it is that they want and need, and then figure out, what the best method is to design that service. And then you've got to study it and evaluate it to see if it works. And that's, to me, one of the roles of an academic department, is to do that kind of exciting work.
So virtual care isn't just about saving money.
Oh, I'm not even sure it saves money, to be honest. I mean, it probably saves money on parking. But I'm not sure it saves money, in all of the other ways. I mean, but I do think there are ways to do it so that it's better and smarter care. And I know that my patients appreciate, being able to do it. And very often for a follow-up visit or a mental health conversation or whatever, there are many, many instances where it's pretty much just as good or maybe better. And so why wouldn't we use it? Sometimes, though, it's not a substitute. And I will say, speaking for myself as a healthcare provider, I went into this business because I like people and I like being around people. And so I hope that part is not totally lost in all of this. These virtual technologies as a means of enhancing and reinforcing relationship, that is also something that we need to study and think about, so that it's not just, we cannot turn primary care into a widget production factory of video visits. That's not the point. That's not the purpose of the discipline.
And let's talk about technology in one of the most fraught relationships, the referral from family docs to specialists. Is there a role there to help that sometimes difficult relationship?
It's such a critical component of this. And I do, so I have been using, as many family doctors have been doing, this amazing service called e-consult. I feel I give them a lot of free advertising, but it is an amazing, amazing service, a government funded service here in Ontario, where I can log into a service online and type in my patient's concerns, issues, what I'm seeing, and lab results, attach imaging, et cetera. And I get an opinion back from a specialist in that area within 48 hours. It's like a secure email thing. So it doesn't work for everything, but you know what? It works for a lot of things. I used it 4 or 5 times last week for patients who otherwise would have been put on a waiting list to see a specialist face-to-face. And I also am unrepentant about emailing specialists, about calling people for an opinion. They can get paid, I can get paid, there are billing codes for all of these things now. So thinking about how do we use technology to simplify the specialty interface. And the trick in that is that the patient needs to be willing to not see the specialist, but rather to trust me to have that conversation with the specialist on their behalf and report back on what I've learned. And that's, again, where the relationship between the family doc and the patient is so important. When you have that trust and that knowledge of each other, of course, it makes much more sense. And so we can massively reduce wait times in Canada if we use this methodology across the board. The trick is, of course, to get that implemented.
Now, the other area we got a lot of audience questions is about something you mentioned, payment, specifically the payment model. So your views of fee for service, is that still appropriate? Should all family docs be salaried? Again, is there a magical formula there?
The sad reality of the international evidence on this, Andre, is there's no good way to pay a doctor. Every method of payment has its pros and has its cons. What I will say is that it seems certainly in primary care that pure fee for service is probably not the best model for the provision of comprehensive care, particularly for people who have complex medical problems. You cannot effectively deal with the issues of a complex older person who's got multiple physical and mental health issues in a 15-minute visit. And so some blended model that includes a little bit of incentive to volume, a little incentive to complexity, a lot of incentive to be in the office seeing patients, and an incentive to take care of your population in a comprehensive way. That's the sweet spot, and it probably involves a bit of a mashup of different payment models.
Now, we only have a few minutes left. I want to squeeze in a couple of last questions. Tap into your big brain. I want to know how can we make family medicine more attractive to medical students? I see them all rushing to specialties. Family medicine spots go unfilled. How can we fix that? It seems so important.
Well, it's my view that what we need to do is not just be preparing the students for the practice of family medicine. We need to be preparing the system to receive them and give them a good job with a quality of life. And by quality of life, I mean the ability to apply their skills in a way that feels good to them. And so I see our department as needing to lead in the health system, not only in the halls of academia. We need to prepare the health system with those good payment models, with those team-based care models, to make it possible for our graduates to practice their craft in a way that they can be proud of. And so I think that is the next frontier for our department, is to really engage with the health system in a meaningful way to try to push for improvement so that our graduates have someplace great where they want to work, and they're not just learning the theory of comprehensive family medicine.
And I hear a lot of graduates say, well, I'm going to go to a specialty because I have too much debt. Can we fix that part? Can we make med school more affordable, or make the payment more fair between specialties and the specialty of family medicine?
Yes, absolutely. We hear these stories about debt. We know that that's a crushing consideration for many of our graduates. And I also do try to reassure our graduates that medicine is a well-paid career in Canada, and that what you need to do is to choose the specialty where you feel that you can have a fulfilling career for the next 40, 50 years. And, the debt doesn't last forever. And so helping people to see the forest for the trees, if you will, I think is also an important part of those conversations.
And one last question for you. Maybe it's born of Canadian insecurity, but I always wonder, is there a country that does this better that we should be copying, or do we have all the solutions here at home?
Well, we've got lots of the solutions. We just don't implement them all at once. We have this e-consult here in Ontario. We have amazing care for complex older persons in Nova Scotia. We've got centralized intake and referral for specialty care in Manitoba. The list goes on that, networks of GPs working together in Alberta. The trick is to bring all of these, build that Canadian made car out of the engine from one place and the body from another, and spray paint it blue for Temerty Faculty of Medicine, and you're done, right? I think that is where we need to go. Is we know what needs to happen. We need to bring that knowledge together and implement it into the healthcare system. And my goal for the Department of Family and Community Medicine at U of T is that we will help to lead that work to build the health system based on what we know the best evidence is, and take all these amazing, smart, optimistic young new graduates and put them out into a healthcare system that works for people.
And put them out there to fix it, to make it a little better.
That's right.
Great, wonderful. Well, thank you, Dr. Danielle Martin, for this engaging discussion. I wish we had another couple of hours to delve into stuff, but thank you again to the audience for tuning in such large numbers as well. Please take a minute to briefly answer the survey. You can see it in the chat box, or there's going to be a QR code on the screen if you want to just answer that way. And all this information will help us plan our future events. And there will be some upcoming Temerty talks. We haven't quite nailed down the next one yet, but stay tuned in your email. There'll be more information again. Thank you again. Stay safe. Make sure you get all your vaccines. And thank you for tuning in.